NHS healthcare, the quest for better patient care is never-ending. Artificial intelligence has a transformative influence on healthcare. AI helps him analyze patient data faster and more accurately. This leads to precise diagnoses and personalized treatment plans. AI also helps in predicting potential health risks. This proactive approach improves patient outcomes significantly. AI is not replacing doctors, but empowering them. Together, they are revolutionizing healthcare. Empowering the NHS with AI hallmarks a revolution in medical care for a healthier future. Because with AI, better patient care is possible.
Hello and welcome to our weekly webinar series on the transformative role of AI for the NHS. My name is Kiran Fulton and I will be one of your presenters today. Now, AI now is becoming a pretty common name. We are talking about it and it is really important to understand AI. This is our third webinar and today we are going to focus on the transformative innovation of NHS using the power of artificial intelligence. Now, before we start, I want to do a quick thank you to the Conservative Friends of the NHS for making this webinar possible, along with our guest speakers. We're going to have a Q&A session after our speakers have spoken, and then we are going to take it on to the panelists as well. Now, before we start, just to let you know, a quick warm welcome to our guests, because this program and our audience, this program is being streamed live on LinkedIn, Facebook, Twitter, and to the audience over here. I want to bring in Dr. Ashraf Chauhan first, who is the founder chairman of the Conservative Friends of the NHS and an orthopedic surgeon. He's the fellow of the Royal College of Surgeons. He is with us right now and he is going to kickstart this conversation on AI. Over to you, Dr. Ashraf Chauhan.
Thank you, Kiran. First of all, I'm sorry that I'm away and I cannot be participating fully, but I will be listening to the debate. Conservative Friend of NHS basically is a political wing of Conservative Party, but the idea behind was that we get a voice heard from the medical fraternity within the Conservative government. And we do all what the political requirements for the party are, fundraising, campaigning. But we are professionals and we are all from medical background. And we are working for the government, for the patients, and we are getting the message from community, from the professionals, and taking it to the government. We have different wings, and this wing is about artificial intelligence, and the mind behind is Dr. Chughtai. I know him for a long time. He has spent a lot of time in this, and this is the right time that we are banging on the door of 10 Downing Street. We visited last week as well, and we'll do another visit just for artificial intelligence. As I sent this previous program to the Prime Minister, and I got the feedback that they were very happy what we are doing, and they have asked us to provide them.
I think we've lost you for a bit, Dr. Chauhan. Oh, I'm afraid we've lost Dr. Chauhan. Should we try connecting back?
Could you take over, Kiran? I think there's some connection issue, perhaps.
Right. So maybe what we can do is we'll wait for a few moments to see if Dr. Chauhan can join or not. Otherwise, we can move to our next speaker. Once again, I'm just going to reiterate the topic today. Our topic today is the transformative innovation of NHS using the power of artificial intelligence. Should we move to our next speaker, Dr. Chughtai?
I think so. I think there is a problem for connection, perhaps.
Okay, no worries. So we'll move to our next speaker, who is Professor Angus Wallace. He retired as a professor in orthopedics in the UK after an illustrious career. He also served as the Chief Medical Officer for Medical City Online UK for many years. He's also the founding fellow of Faculty of Clinical Informatics and has been an advocate of digital health for over 2 decades. Now, Professor Wallace and Dr. Suhail Chughtai have co-authored a book called Telemedicine, a novel way to fight the pandemic. And this book was a narrative of how medical experts and technology experts came together during COVID-19. The question is, can they come together again for another success story with AI? So we're going to hand it over to you, Professor Wallace, and I would really want you to start by telling us about the kind of ethics regulations of AI that we need to know about before we enter the forte. It's over to you.
Thank you very much for inviting me. It's an honor to come and speak to you. I am very much an advocate of AI, but I'm going to talk to you today about the guidance that has been recommended by the World Health Organization. And I'm just going to show some slides which highlight that guidance. So I am now I should have my slides up, have I?
Not
they're
yet.
waiting to come up. No, not yet. There's a present button at the bottom and screen share or slide share. The present button at the bottom, and then there is a screen share button after that.
Hold on. Select window screen. Yeah. That one. Allow. We're there now?
We got your slides.
Yeah, let's just get on to the main one.
There we go. Yep.
Right. This is what's happened here?
Yeah. So, Prof, we can see your slides on the screen.
That's fine. During the last month, the World Health Organization has recommended regulatory considerations on artificial intelligence for health. And I think the guidance that they have provided is extremely valuable. The WHO Director General, lovely guy, who is General Tedros Ghebreyesus, has highlighted the report by saying the introduction of AI in medicine is very promising. At the same time, AI can involve an element of risk through unethical data collection, cyber attacks, and malfunctions. That is really important. And when we use AI, we have to try and do the best we can to avoid these problems. And the WHO guidelines are designed to help countries to regulate AI and utilize its potential, whether it's to treat cancer or recognize TB or carry out X-ray imaging. AI does have weaknesses. AI technologies include comprehensive speech models, but often these are being implemented too rapidly without knowing exactly how they work and what could also harm users. When using health data, AI systems may also have to access sensitive personal details, and these need to be protected. So there are 6 areas for regulation of AI for health. They're recommended by the World Health Organization. They stress the importance of transparency and documentation. And within the UK, there is a problem at the moment with confidence in healthcare records and with transparency. Risk management is important. You've got to make sure that the intended use of the information that is being assessed, used, and facilitating medical care is doing the right thing. And we got to avoid cybersecurity threats. And it's really important to carry out regular external validation to make absolutely sure that AI is safe and facilitates regulation. The World Health Organization says that the countries all should have a commitment to data quality. Now, data quality is a big problem in medicine because data quality can be poor, particularly when you are transferring from paper records to electronic records. And the challenge posed by important complex regulations such as the GDPR can make it very difficult to actually use IA in the NHS setting. It's important to foster collaboration between the regulatory bodies, and we are trying very hard to do that in the UK at the present time. It's important that the external validation of the data and the clear definition of the intended purpose of AI systems help to ensure safety and facilitate regulation. We must make a commitment to data quality. Regulatory provisions must also deal with questions concerning privacy and data protection. We have had episodes in this country where people have had their medical records leaked by accident, or information about their medical state leaked by accident. We must avoid that happening. And we really do have to improve collaboration between the regulatory authorities and others. So I'm going to come back if I can. I need to stop screen. There we are. Am I back now?
Yes, you are.
And I'm quite happy to take questions at the end of the presentations, all the presentations, but I'll deal with anything that you want to ask at this point. Thank you very much.
Right. I think we'll do that, Professor Wallace. I think we'll take the questions after, and we'll get to Dr. Suhail Chughtai right now. Now, let me introduce him. Dr. Suhail Chughtai is a London-based orthopedic surgeon with wide clinical experience in and out of the NHS. He's also a strategist in the field of AI and telehealth. He has designed over 12 major telehealth software, and some of which have been acquired by international healthcare providers. Dr. Chughtai holds a certification from MIT USA in the Artificial Intelligence Empowered Healthcare and a fellowship in clinical telemedicine. Besides being a Microsoft certified specialist, he is currently serving as a chief technology officer for a Dubai-based healthcare company called the Health Bank Global, and also as director of health, Conservative Friends of NHS. We'll hand it over to you, Dr. Chughtai, as you will be giving us a full-on demonstration on transformative innovation of NHS using the power of artificial intelligence. Over to you.
Thank you very much, Kiran. That's a very illustrious introduction. I appreciate that. So I think it's a journey. It's a very interesting journey, and it is still going on. And every day I find myself at the beginning. That is the generative AI. After having done 30 years of active computing, 20 years of healthcare computing, when I wake up with generative AI in the morning, it feels like it's starting again. That is the depth of this. It's like a watershed line. It is just like the broadband came into the market. That is what the effect generative AI is creating in the digital market. So allow me to take you forward and I'm going to introduce Virtual Jennifer. Virtual Jennifer is a persona I created and trained for orthopedic practice. I thought this may be a good example to start with. If an orthopedic surgeon practice can be maintained and managed through virtuality in the big, like giving appointments, then it can go to any practice. But I want to share and take your views. And remember, it's only the beginning of this generative AI era. So as a patient would use an app to connect to a clinic, or they can connect to a doctor. In this example, it's my clinic being shown, so that if the patient connects here, then it'll go to another screen. But before that, the patient would have signed or seen a disclaimer that the medical advice given by the system is through an artificial intelligence system, which is learning. And if you have any doubt, there is a number below in the disclaimer. They can always call and ask. But remember one thing, that acute conditions are not being managed here. Life-threatening conditions are not being managed here. When the patient calls in, the system has capacity and it's being trained that if there is a pain of intensity, the system will immediately say, look, it's beyond me, please call the doctor or call 999. And that disclaimer part will come before patient reaches this. So once the patient reaches that screen, they will select a doctor and then this will start. And I'm just going to show you a 3-4 minutes demo, a screen video recording of how my practice will engage with a patient. Now that is an example that if I can train computer to do this, any computer can be trained for any practice. And so this is the beginning, and I just want to show you Virtual Jennifer, because she was the first secretary of when I took a consultant post back in '95 as a locum consultant. My secretary was Jennifer, so it's a tribute to Jennifer who was taking such an inexperienced young consultant, and she kind of borne all the silly things I've done at that time, being a very young consultant. So I'm starting now to share this demo. Please take a look. Good morning. So, by the way, this good morning is not from me. I'm acting as a patient called Shakil Khan, who is about 40 years of age, and he has called to take advice for knee pain and want to make an appointment with a GP. I want some help regarding my right knee pain. So I have trained this to ask the name first so that we can control the documentation, because all this documentation is going to my clinic. So if the patient forgets to tell the name, the system is now trained to ask the name. And that is an important point, that we can train the system. My name is Shakil Khan. Again, this is for knee pain. This is the musculoskeletal system. So the computer has already been trained, the generative AI, but I added few information that after the name and then start asking about the detail of the particular region. It has been trained to ask the age as well, which this time it skipped. So I'm training it further to ask the gender and the age before asking the details of the symptom. I have been facing a problem with my right knee for the last 2 weeks. And the pain is mainly at the front of the knee. So you may notice that it is summarizing at the same time, keeping link to what has been registered. At the same time, it is doing inert advice, like simple methods to solve or help the pain. But that's not all. As I apply ice on it, it feels better. I'm also taking some paracetamol, which makes it temporarily better. but it comes back as soon as I start climbing stairs or start walking for 10 minutes. So that is where it is a safe approach that once the documentation, the information has been taken, the patient's intent is to take an appointment with the GP. If it's not, it will be evident on the next screen. If it is, the patient follow the track. So at this point, the patient is being asked to have an evaluation of the symptom by physical examination. For that, an appointment is suggested. Can you possibly tell what could be wrong with my knee? I am about 45 years old. I want to explain one point here. 10 years ago, when I made a chatbot, I used Python language. That was based on what if and the keywords. Now, in this system, you notice that the patient is now giving his or her own ideas. It's not using keywords. It is giving thoughts, and natural language processing based system will follow the unstructured documentation and the background. So whatever the patient has said now, it's not on the screen. It's a totally different direction. If it's a standard chatbot, that will stop here. But because it's a generative AI chatbot or artificial intelligence of different kind, this will continue because it will look back on the unstructured system. So you can see that patient has been given some information about knee pain of 2 weeks duration without any trauma, acute trauma or injury. But at the same time, the direction is towards the appointment, not taking responsibility of actually treating this patient by the AI. I do not have any other medical issues, although I go to gym quite regularly, and I remember increasing my routine at the gym last month. Could that be a reason? So the AI or virtual Jennifer has registered the new information, and that she's going to pass on to the consultant or the doctor in the clinic. But it's important to stay anchored to where we are. A standard chatbot made on Python or what if technology is going to stop here or fail or take in a different direction. And that is the benefit of this new artificial intelligence. Okay, fine. Can you suggest me the schedule of appointments? So this is what I provided when I was training this model. I was creating a persona, and I provided as much details as possible. Again, training of this system is very important. You need to train in such a way that what is on the screen, create 10 MCQs of that. That is the possible, whatever information I'm giving on the screen, there could be 10 questions raised from that. Answer to those 10 questions would be in the system. And also, what is not on the screen, that direction we should keep ready. So the training part is very critical, very important. And at the same time, then linking this to the website or the email is a second part. I can come on Wednesday at 2:30 p.m. So in this system, I've trained the virtual Jennifer chatbot to ask for email address. If the patient had said, I'm not comfortable giving you my mobile number, then the next question was, fine, I accept that. Can you please provide me your email address? So that would have been my next option if the patient has refused to give the mobile number. Okay, my number is 0739 549 2121. What is the cost of consultation? So that came from this payment, because I mentioned payment here. So what could be the possible question a patient will be asking at this point? So that direction is always in the backup. Okay, that's fine. But is there any parking space? See that parking, there's no word mentioned of parking here, but there's word of appointment. So from that, you need to deduce what is patient thinking. You need to go out of this screen and think, what can patient ask next? So I provided this information that we have 10 spaces, and then they are a first come, first serve basis. And then there's off-street parking as well. So that information was in the backdrop. So what is the nearest tube station if I can't bring my car? So again, you have to think that when you're training chatbot, that patient cannot always bring their car. What is the next option? So as I said, that while training, that is the critical part, that you need to really go very creative, imaginative, and beyond the screen. And then also, when you say Knightsbridge, then you may need to tell from Knightsbridge how to reach your clinic. Thank you. Also, please tell me if I can bring my brother and his wife with me, as they would be accompanying me on that day. Can you notice that I said accompanying me? It put committing. Maybe my accent is not picked up. But look at the intelligent chatbot. That's the important aspect. It understood it's not committing. I didn't mean committing. Just take a look. That is fine. Thank you. And just last point, if I want to reschedule this appointment, can you provide me a number and name of the person whom I can call? Again, this is a backup that if you go by a Python chatbot, this will not be expected. Great. Thank you. I appreciate that. Bye for now. Good morning. So that's how it ends. And I just want to reiterate that what we've gained from this. I strongly believe that there are benefits of artificial intelligence nurse and clinic manager. First of all, there is 24/7 availability. People are traveling. They can make appointments even they're abroad, they're at airport. They don't need to wait for the 9 o'clock in the morning or 8:30 in the morning for the narrow window to make an appointment. And just look at the figures. There was a survey done in 2022 at, I think it was June to August. And 75% patients faced difficulty in booking face-to-face appointment in the last 12 months. They could book online appointment, video appointment, but only 16% patient wanted that. 26% were unable to contact the GP practice at the times suitable to them. That is the key point. 43% reported making appointment on the phone a time-consuming process. So, structured pre-consultation documentation, I would be presented this set of notes before the patient comes to my clinic. Great value to me. Cost-effective and time-saving. All these notes will go into the patient system or come as an attached PDF file. It's simple, it's cost-effective because this will just cost in the beginning, but after that, there's no person sitting to manage that. There is efficient use of GP surgery staff. The person who was doing this duty before can now manage something else. That person can stay on the reception to manage the patients coming in person. She doesn't have to be on the phone while she's managing patients coming in person. And the engagement is very enhanced. You may say that it's a virtual system. Why the engagement is enhanced? Because the with learning and training, the actual system will recognize and will become very close, kind of associated with that, and will be very sympathetic. Will never forget the courtesy. Will always make sure that even if there is a tough kind of rushing appointments, people are going one after other, the computer will not forget to be courteous. There's no time pressure. Like patient can stay as long as they want, and there is no time loss of GP surgery. The basic health guidelines are given for the non-urgent conditions, which means that those ones can be managed while the patient is waiting for appointment. It's not that the patient has to come to GP to find out what to do. It's multilinguistic. We can change it to many languages. In this example, I kept the other side silent, but actually you can always make it speak. Patients who cannot reach the clinic or hard of hearing, they can make an appointment through the system if they are literate enough on computer, or somebody else can do it for them. And it is minimized for human errors, because the appointment given will be always from the schedule on the system. It cannot make an error. So, I mean, given all the facilities, all the benefits of that, I have been convinced. I was partially convinced when it was Python type of chatbots, because they could lead to error. With generative AI, I don't see a problem. And mind you, we are only starting. It's going to go a long way further on this. So I really close with that, and I'm very delighted that we have been talking about it. This is something not very easy to understand at the beginning, but believe me, it's coming. It is there. Thank you very much.
Wow, this is fascinating stuff. So this is wonderful. Let's move it along. I'm sure the panel would want to come in right now. So I'm going to hand it over to Dr. Simon Niaz. Dr. Niaz is a consultant psychiatrist who is also the deputy chairman of the Conservative Friends of the NHS. Dr. Saima will introduce the panelists, and let's keep the show going. Saima, over to you. I think you're on mute. Yeah.
Yes, Saima, we can hear you now. Please go ahead.
Okay, thank you. Thanks, Kiran. Thanks, Dr. Chughtai. I'm going to, first of all, good evening to everyone and welcome again. And I'm going to first introduce our panelist, Professor Bilal Ahmed. We are very glad that he's able to join us tonight. And he's an MD from Rochester Medical School. Our specialty is internal medicine, AI, and telehealth. Activist. He's a medical advisor to the Medical City Online. And what I'm aware of, he has the experience of both worlds, UK and USA. And as well, I'm going to say that he's the CMO, Chief Medical Officer for the Rochester Uni and affiliated hospitals. So I'm going to request Professor Bilal Ahmed if he can share his interaction with AI for 2 minutes, and then we'll come back to you again for question answers at the end.
Thank you, Simon. And Suhail, that was fascinating. I love the claps at the end of the presentation, by the way. So I can give you a very quick perspective of where we are in a US healthcare system as far as AI is concerned. So maybe we're not as advanced as Suhail's virtual Jennifer, or is it Jennifer? I think, yes. So, but we are kind of, putting our toes in water in those kind of technologies. I have to tell you that AI in the US is it's a little bit of a hard sell right now, because something we call switchover disruptions. So this is basically a phase-in period for new technologies that upends, operations. So that's why people are kind of saying, should we do it? So what we have come up with, we think that we must build trust in AI with 3 very critical constituencies: the providers, which is the physicians, the patients, and the public. So we are changing the narrative about the purpose of AI. I think that's very important before we kind of go into this, because when we say AI, people get very disturbed. It's just like, when you do genetic modification for crops, they say, okay, now the computer's going to look at me. You will not see me. What does this mean for my healthcare? So what we have been doing is we're telling people that this augments the expertise of providers. So AI is not going to take up the job of a provider; it's going to augment their expertise, and also enable them to spend more time and give more attention to the patients on higher order cognitive tasks such as problem solving and communication. Exactly what Suhail was doing. So he was taking away that kind of a rote kind of a thing and putting and having the provider or the physician have more time for the patient. So the other thing that we are doing is we are paying very careful attention to how applications are implemented. So the AI should demonstrably improve outcomes and provide better experience. It has to do that. Otherwise, people are not going to buy into it. I can give you a very quick example. So back in 1991, the Institute of Medicine in the US, they recommended that, we should go into electronic health records. So this is the way to go. We should do this. It's something which is going to, put everything together. It's going to streamline things. But 17 years later, only 2% of hospital and physician practices had bought onto that idea, and they had electronic health records. Still, in 2007, the US government, they gave these huge incentives to hospitals and physician offices to buy EHRs or electronic health records, and that's when it started gaining traction. What was happening at that time was that physicians were very kind of dismissive of this. They thought that their independence was going to be taken away, that it's going to be administration is going to be looking into them. They will be asked to do certain tasks that they are used to do in a certain way. So any change in human behavior is very tough, and any change, even for the better, is very tough, because once you're used to doing certain things in a certain way, you really don't want to change. The example I was going to give was exactly at the same time IOM said that you need to go into EHR. The laparoscopic way of doing surgery came to be. So there was a laparoscopic cholecystectomy. People were saying, should we do this? Shouldn't we do it? But that took off like wildfire. And why did that happen? It's because the physicians wanted to do it, the patients wanted it, it was better outcomes, it was a quicker operation. So they could see the benefit out of this. And that's why it kind of gained traction very, very quickly. So what I'm trying to say is that when we are trying to introduce a new technology with all the things that it can, if the promise of it upending the way you do things, you have to make sure that the people who are going to use the technology are going to buy into it, because it's going to benefit them in the longer term. So that's the stage we are at right now. So we have introduced AI into a number of things that we do on a daily basis. So it's certainly a part of our imaging software. So it picks up on digitals and little things, and it kind of tells you that this may be cancer. So because it can compare and contrast to billions of images compared to the human mind, which can just see, maybe 100,000 images. So that has gone very, very well, and the radiologists love that. The natural language aspect of AI, I think we are really kind of using that the best we can, both for patient charting as well as documentation, as well as on picking up on things in which we can actually, in the US, we have to bill for our services. So the natural language recognition platforms actually kind of recognize certain terms. Like, for example, if it's a severe sepsis, you can bill more for it. So it kind of recognizes that. But, the excitement has been in the large language models like the ChatGPT that we use. And what people are kind of concerned about is that, it may have implications about patient confidentiality and stuff. So we have been kind of trying to deal with those kind of aspects as well, and trying to convince patients and physicians that, their information is going to be protected. And I don't know if I can present my screen and tell you exactly where we are right now. So let me just try and see. Actually, I don't think I can, but I wanted to tell you we are right now working with Amazon. We are also working with a large number of healthcare companies like CVS, which is a large healthcare company, Humana, which is an insurance company. So we're all coming together, and we have put up these kind of health stations. We call them HIGI stations, or HIGI, which are in all the truck stops in the country, which are in all the petrol stations in the country. So people can go up to these HIGI stations, as they're traveling, or they can go up to these in Walmart and other grocery stores, tell us what their problem is. The stations do their basic vital signs. AI picks up on these complaints, and kind of what Suhail was showing you, it recognizes natural language, and it then sends these to the appropriate consultant. So the patient says, for example, I was traveling and I have this rash and I don't know what it is. It takes a picture. The picture is saved. It goes into a database, and there is a program which kind of tries to recognize the picture. It's through Visual DX. That's one of the dermatology programs that we have, and comes up with a differential diagnosis, and it is routed to a dermatologist for a consultation. And the patient is told, if you're traveling, you'll be in Florida in 3 days. You will have an appointment with a dermatologist, and we'll see you and we'll talk about this. So a lot of this is kind of based on the ChatGPT large language recognition capabilities that we have included into our software program. So that's kind of where we are. So I think what I really want to say is that we are at a stage in which we have to prove that AI is not going to take away jobs, but it's going to augment our capabilities. And how it can do that, we have to tell people how it can do that and have better outcomes. And it's good for patient safety and good for, in the bigger picture as well. So that's kind of where we stand right now. I had a presentation. I don't think I can present it because it's not letting me share the screen, but I'm happy to take any questions.
Thank you so much, Professor Bilal. That's really captivating, your share. And I could not resist. My attention was focused on that. Thank you, Dr. Chughtai. We'll get back to you after I'll introduce other panelists. So our next esteemed panelist is Dr. Rajinder Paul Singh. He's a consultant transplant surgeon from Manchester. He was trained in abdominal organ transplantation and immunosuppressive strategies in the United States. He's a clinical researcher with several peer-reviewed scientific publications, and he's also infection prevention and control lead. So can I please check with you, Dr. Rajinder Paul Singh, if you will be able to share your interaction with the artificial intelligence or around you. So if you'll say 1 to 2 minutes, thanks.
Thank you, Saima. Thank you, team. Thank you, Suhail. It's a real honor and pleasure to speak to you. And I would like to send my warm greetings here from Amritsar to all of you. We did have this discussion last time, and all the esteemed members have clearly highlighted most of the salutary things that the artificial intelligence can get. Last time I did mention about how the electronic system that came into our hospital has changed everything, made life easier, patient flow and pathways are better. I had also discussed about how the sensors like diabetic sensors and management system with insulin pump has replaced pancreas transplantation, as a solitary transplant option is now less considered. Likewise, there are many more advantages. I think we also touched on the confidentiality aspect and how to have an ironclad system to safeguard. And I think most of the august speakers highlighted all of that. Now, what I would like to say is that it's a practical aspect. When I was in the US as a fellow in 2007, the electronic system was already there in North Carolina and Minnesota. And we have had it in Manchester just about a year ago. So clearly we had that system, but after almost 15 years. And so clearly we are catching up, and this is the way to go. Artificial intelligence is here to stay. And the reason is that when I was a medical student, the number of diseases that I knew was less. And medicine has grown by leaps and bounds. Every day the information increases. The management strategies in our armamentarium, they keep growing more and more. Likewise, the robustness of data collection, etc., also is growing. The legal aspects of medicine is also alarmingly growing. So all of this cannot be simply matched by the human brain. So it is very, very essential that we get in as much as computerized system to robustly provide input into the system to make it safe for ourselves, the patients, and to give a better patient experience. It's also going to help in the patient management strategies such as robotics, genomics, administrative management, and also the strategy that Dr. Chughtai has just presented to us. I will ask him later why he named her Jennifer. Uh, Other than that, one also has to keep this in mind that the robustness of the system will still depend upon the human brain. As the Dr. Chughtai said that he has fed into the robot those questions, those diagnostics, and as a result, it is only able to narrate back what has been fed into it. So this underpins the most important aspect of the technology, that we have to provide a thorough input into the system so that there are no leaks and the system becomes as much as possible foolproof and robust. Now, one thing that I would like to highlight, for instance, in many hospitals is when patients come, they have a sheet with them that, oh, I have come into your clinic, but I do not know whether this is a clinic for the nephrologist, whether this is a clinic for vascular access surgery, or whether this is a clinic for a transplant assessment, or whether this is for an iron injection for my anemia due to kidney disease. They have a generic letter that comes to them. And this highlights the fact that the system is not robust enough that it gives the patient the adequate information. It brings the patient to the clinic for sure, but it does not let the patient know why he has come to the clinic. So, as Dr. Chughtai has so beautifully illustrated, it would be useful that we incorporate all of these aspects into the artificial intelligence so that when the output is derived, that output creates less chaos and it allows for a better patient information and also a better patient experience and pathways. So that's the most important things. So to summarize, I would humbly say that since the information that we are nowadays dealing with is so huge and every day it's piles of it is adding up, we would certainly need to have the robust artificial intelligence input. And as doctor mentioned that cholecystectomy at one point of time was frowned at. In fact, the person, I think Kohler or someone who did the first lap chole was put behind bars. And later, and now you can see that open cholecystectomy is gone. Likewise, in transplantation, robotic surgeries are now coming up. In very obese patients, the robotic surgery is now considered to be more safer to do a donor nephrectomy, and if you do an open operation, then it's more challenging and also more tissue or traumatizing for the patient. So clearly the robotics is here to stay and it's growing by leaps and bounds, and in the coming 20 years probably it's going to replace, but it will be the human being only who will be operating the robot. So clearly there is no threat to the jobs. At the same time, we are facing a lot of job shortages based on the increased workload, increased patient numbers, increase in the population, increase in the elderly population, as a result of which the morbid diseases, diseases related to old age, malignancies. We have got treatment for liver failure like transplants, for kidney failure like transplantation. As a result, what we have to offer also has increased. All of that has to be handled through the methodology of artificial intelligence. And I might say that I may say that I'm mightily impressed with the credentials of Dr. Chughtai, which I did not know before, how much training he has undergone in the past. And I think we need more like him to put into the system and make the process very robust for the United Kingdom. And that is the way to go. I think I would finish here. Thank you.
Thank you so much, Raj. Thanks. That's incredible. And I'm now going to introduce our next panelist, Masabi Warsi. She's a distinguished musculoskeletal specialist practitioner with a notable presence in Nottinghamshire, where she serves across 10 GP surgeries. Her expertise and dedication in the field make her a valuable contributor to the healthcare landscape in the region. And with a rich professional background, she has also contributed to the sports sectors and working with different events. And I'm going to request Majmi if you are able to share your views about the use of AI in your practice or around you, or what are your views about its use? Thanks.
Good evening, everyone. First of all, Thank you, Dr. Chughtai, for that insightful presentation. And good evening to all the esteemed guests here. Um, I mean, I would first like to mention the need of AI in primary care. I work in a GP practice where we have across about 23,000 patients. And when we talk about, patients trying to get through phone calls, I mean, a lot of them don't even get through phone calls. This model, which Dr. Chughtai just presented, that would be just such a great asset to primary care. The other thing I would like to highlight, several times we get patients who come in who have already spoken to, receptionist, and they have already given information to the receptionist, but they have not documented everything. And then they come to us in the clinic and they'll be like, I don't want to tell you what I've already mentioned as to what's wrong with me. Why haven't you gone through my notes? So I think this would be such a good model, because the clinicians who's going to see the patient, they have already got all the information that they need in front of them, which will help us document and make things a lot easier. Coming to using AI in what I do. Obviously, I use ChatGPT, as I mentioned in my last webinar that I attended. Well, I don't use patient information, but it does help in writing letters to consultants, because in primary care, we are like, 15 minutes appointments back to back, around 30, 40 patients a day. So which has obviously helped in making our life easier. So and working as a physiotherapist, using AI for exercises also helps in tailoring the program for the patients. So, which is also another good thing. So,
That's
yeah.
great. Thank you so much, Vasmi. So I'm going to hand over to Dr. Chughtai.
Thank you, Saima, for conducting the introduction round. We have questions coming, and I want to start the QA session. We'll try to keep it brief to 10 minutes. The question is from one of the, I think, orthopedic surgeons, if I rightly remember. What if the patient does not ask any further questions? Does the chatbot close automatically? With the permission of rest of the colleagues, I like to address this because I was presenting this model. Atif, the issue is that the chatbot is not Python based. It's not based on what if. It is intelligent enough to understand that there is no question coming in. Now, funny enough, I can time it that if there is no prompt, no question, put the question on the screen. Have you gone? Have you left? Do you want me to wait for you? Now I can train Jennifer, virtual Jennifer, on that to be that humble and courteous, that if there is no response on the screen, give it 5 minutes and keep asking questions. And do you want me to wait? And then at the end, she can say, sorry, there's no response. Maybe you have a network issue. We'll connect again. I'm here if you want me. That I can train. This is the beauty of this generative natural language processing, large language model AI. Python, the traditional AI, could not do it. I hope I answer your question, Atif. One more long question, which I want to just put it here. Now, this question, I want to put it to Professor Angus Wallace. Prof, Daniel is asking, the crux of the question is, can NHS on a large scale, would that be problematic to apply a large language model on a larger scale rather than a small practice? Do you want to address this one, Prof?
I believe the NHS is currently thinking about it and beginning to work on it. One of the things that I have been surprised about is that when we have patients who do not have English as their mother tongue in the clinic, then we are required to have a translator in the clinic to help them explain what their problem is. I do not understand why the NHS has not converted to using Google Translator or some of the other translating platforms automatically within the NHS, because the amount of money they would save by doing that is phenomenal. Now, that is a bit of AI that is practical, is working. And I certainly have a family who have gone abroad, taken their iPhone with them, and are able to communicate with people who don't speak English through their mobile phone. Why don't we do that much more within the NHS? So I think we will see the NHS moving, but the NHS, the National Health Service in the UK, is like a tanker. It chugs along in one direction, and it takes a heck of a lot of effort to move it in another direction. And I think there are a lot of people starting to push it in the right direction, but it's going to take a while to get there.
Thank you, Prof, for your input. I believe that if you divide NHS into small chunks, a GP practice, that is still a small unit. You don't have to search for the whole NHS records. A GP practice and then a particular GP, they can start a pilot. So, Maz, you have been very vocal about the use of ChatGPT. Can you perhaps share an experience where you found it difficult to understand why this answer came up? Or where do you find difficulties in using ChatGPT where you find it's not practical? Let's hear from you, Maz.
I think with any tool that we use, for example, if you use Siri or Alexa, I mean, whenever you are asking a question to these artificial intelligent, um, you always don't get the straightforward answer. Like sometimes you have to keep changing the words that you're using. For example, I once had a patient. It was a very rare condition. This gentleman had I thought he has a trapped vertebral artery occlusion, and and he had symptoms where he was getting, but it wasn't very straightforward. So I went on ChatGPT. Can you tell me the rare neck disorders where the vertebral artery could be occluded? And it actually gave me an answer: Bow-Hunter syndrome, which is actually, there are only a few case studies registered. So if you use ChatGPT in the right way, I mean, it's a very, very useful tool. But yes, it can be challenging with the words that you use.
Well, I think we have one issue. I want to come back to want to come to Mr. Singh, that he has been in a very complex kind of situation where transplant surgery, very complex patients. Do you think you can, once the patient have operation, they go home, can you leave a questionnaire online through ChatGPT so that they don't have to call the hospital? They can take basic information. Mr.
Yes,
Singh.
certainly. We should be able to do that, but in a graded manner once we are able to establish a bit of a safety netting to the process. Of course, that would be very good. A couple of things I wanted to say, just to add a bit of a humor. It's a little fable. A man was singing in a piece of bog, in a swamp, and there were two people standing there. One was a robot with artificial intelligence, and one was a human being with a level headed brain. And basically, the man had sunk up till his neck. And the question was, we have to salvage. The robot thinks that we should salvage whatever can be salvaged. And the head was above the level of the mud. So he chopped the head and brought it back. Whereas the human being who was present, he pulled him by the hair and brought the whole thing out. So that is where a bit of a difference may lay, and which is where the intelligence, the methodology with which we put it into the system, that we avoid some disasters are there. And another small instance is somebody was driving a Tesla car, and he had put it on his artificial intelligence automated driving mode. And obviously, the car will slow down when another car comes in the front, but it will not slow down when a car comes from the side. So, what happened? A car came from the side, and this car just went and banged into it. The insurance company paid out, putting at fault the other person because it was her fault that she came diagonally across. But in fact, it was the fault of the guy who was driving the car, where the sensor didn't detect a sideway entry. So that is where the Tesla has got a deficiency in the AI. I guess these are some of the public worries which intelligent people like you will be and should be able to address and bring a bit of a safety netting to win public confidence. But as mentioned, there is no other way other than going the way of artificial intelligence. Thank you.
Absolutely, Mr. Singh. It's early days. Bilal, you have given us such a beautiful illustration of what you're involved. I remember when there was COVID in New York, you were leading anti-COVID or COVID prevention campaign and then fighting the disease hands-on. If there's another pandemic, God forbid, do you think artificial intelligence has a preventive role in medical healthcare systems? Can it prevent a disaster?
So, Sale, this discussion is so important, and this is kind of what we are looking into these days. So, we really think that if this is a predictive model and it's a diagnostic program like ChatGPT, and what Maz was just mentioning, it should be very carefully curated by physicians who understand the disease and how it presents and what people might say as to what the symptoms are. Because you might know this, we call this hallucinations. So ChatGPT actually hallucinates or invents facts. These are diagnostic biases that get into the outcomes of AI, and they're based on the script that is given to the program. They may be based on race, to what Professor Wallace was saying, based on language or based on your accent. All of these characteristics introduces biases, and the AI started to hallucinate. So it's a job for us, for people like you, Suhail, is that physicians have to be involved at the back end of these AI programs so that we can just reduce the noise in these programs. So to your question, if let's say there's another pandemic, another virus, or whatever else, the AI should really be trained to recognize the symptoms and to come up with options and solutions. And that is not going to be from the ChatGPT we have now, which is the large language we have now, which has been programmed by God knows who, by a college kid who doesn't really who can't connect the symptoms together with the outcomes. So I think physicians have a duty to participate at the back end in all these in all of these programs. Actually, I have my slide, and I don't know if I can present it.
Now we have 2 minutes before we close.
Yeah.
Is it possible that I can engage you in a proper presentation on one of the webinars? Because I think most of people, we all want to hear from you. Would it be possible to leave the slides for the next program?
Sure, absolutely. No, I don't want to take any more time, but these are exactly the questions we are struggling with right now. So we have something like what you just described, the virtual Jennifer. They recognize language. They triage things. It's not based on chat functions. So it's not maybe as advanced, but it's something which it's learning as it goes. Yes. So we can compare notes.
And also, Bilal, which you mentioned that the doctors have to be involved in technology. I love this sentence. I think this is where we are missing out. Technology, what is more difficult than a human body? If we have understood human body, technology is a child play. I am a humble example of that. I am one of the doctors. I've just taken it up and fought it because I don't want medical professionals to be guided by people who are not dealing with patients. This is my motive to be in technology. I want doctors to lead technology, relevant technology. This is my way, my kind of understanding of this. Before we close, Kiran Fulton has asked a question, a wonderful question, which I want to put to Professor Wallace. The question Kiran has asked, if Jennifer and such models do come in, would it be a challenge to train current staff in the world of AI? Prof, what is your take on that?
Edinny Ken, you see, I'm originally from Dundee, so I didn't ken what you're talking about. And I think
AI will not understand that. You're right.
We've got a real challenge with accents and all sorts of things. So I think we've got a long way to go. I can tell you, Suhail, that the NHS did invest a lot of money in a project during COVID in assessing coughs. Someone somewhere believed you could diagnose COVID from the cough the person had. And there was a lot of money invested in that, and that had a bit of AI in it, and it was money that didn't bear fruit. So I think it's always a challenge when you're going down this route, the technology route. You've got to go for the easy things first and the more difficult challenges later.
Yeah,
Absolutely.
it's like they'd had homing pigeons in guided bombs in the Second World War, and they went all over the place. So it didn't work.
Absolutely. That is one example. But remember, Bilal and Prof. Angus and everybody, that when you implement new thing, there have to be mistakes. There have to be expenses spent and money lost. So it's important to understand that we didn't step on the moon in the first attempt. There were points we had to miss out. So towards the closure of this webinar, I really personally enjoyed it very much, talking to everybody here. And I want Saima to close it formally, the panel session, and Kiran to close the program formally. Saima, over to you.
Thank you, Dr. Suhail, Chughtai, and I would like to thank all panelists on behalf of Conservative Friends of the NHS for taking your time, especially Dr. Raj Singh, who's on his holidays and joining from India, Professor Bilal Ahmed from America, USA, and we would love to hear from you more in proper as a special guest for our webinar with Dr. Chughtai, and Mez, who is our very dedicated and loyal member as well. And are all participants who have joined, and I received so many messages as well while webinar was on, the interactive discussion and such a captivating and fascinating topic and discussion. And Professor Angus, thanks so much for joining us. We haven't forgotten your telemedicine course during the pandemic with Dr. Chughtai. So people still talk about that and they refer to that. And thank you, everyone, and all who have joined online. And over to Kara. Thank you.
Thanks a lot. There's so much to discuss, so the conversation needs to keep going. We will be back next week as well. We will confirm the time of it, but we'll be back for another webinar next week. Thank you for everyone joining, everyone who's there online, all the participants, all the audience. Have a wonderful rest of your day, and goodbye.